Yes, hello, doctor.
Hi.
Yeah, ma'am, we are live now. Okay, we can start with the session now.
All right. Yes. Can I start now? Hello.
Yes, yes, doctor, we can start.
Okay. Is there any introduction? Or I'll just go on.
No, ma'am, we can start with self-introduction.
Hi. Hello. Hello, all. I am Dr. Aparna Krishnappa. I am a consultant dermatologist at Eternal Aesthetics, Film Nagar, Hyderabad. I hope all of you are doing well today. Welcome to my webinar today. The topic is hyperpigmentation and its management. Um, So first, let's know what is hyperpigmentation over the face. So which we all are dealing with, especially Indian women and men, because of the skin types what we are having. So first, I'll go with the table content, which is first introduction, and then I'll talk about epidemiology and the methods of diagnosing, management, recommendations for managing hyperpigmentation, and future directions and conclusions. So first, let's know what is hyperpigmentation. It's a dermatological condition characterized by patches of skin that are darker than the surrounding skin, which can appear over the face or the back. Basically, what we are all dealing with a daily to daily basis as dermatologists with the patients is coming with the complaints of patchy discoloration over the face, which could still take a toll on patient's psychological life and daily life. This what is this pigmentation actually? It is due to the upregulation of the melanin deposits which is in the skin. So melanin is just nothing but the pigmentation cells which produce the product called melanin, which keeps increasing over a period of time over the skin. Although it is not harmful or lethal disorder, it can definitely affect the quality of life of patients by affecting their emotional and psychological health. Due to the resistant and relapsing nature of this pigmentation over the face or body, it can be challenging at one point to select a appropriate treatment. So, what are the types of hyperpigmentation we deal with daily basis? One is PIH, which is nothing but post-inflammatory hyperpigmentation, which is a common acquired cutaneous disorder which occurs after skin inflammation. For example, skin going under history of acne, which heals with the PIH, that is dark spots, or any kind of injury. Next comes is a melasma, which is a skin condition which has patches, the dark patches and spots which are darker than natural skin tone. And next is actinic lentigens, which are hyperpigmented spots or uneven patches that occur due to sun exposure. The actinic lentigens can also be present with brown, tan, black spots over the skin, which also occurs in the form of ephyllites or DPNs, which is dermatosis papulosa nigricans, which follows after the constant UV radiation. Normally, we can expect that over the nose, around the face. Also the chest and back. Next comes melasma or chloasma. Melasma is nothing but larger patches, like I discussed. It's a larger patches of the darkened skin. Again, chloasma, the same kind of patches which occur post pregnancy or during the pregnancy. We call it as chloasma because of the hormonal changes, mostly estrogens. And then is like I said, PIH, which are the spots which follows after any skin injury. There are other types of pigmentation apart from PIH, melasma, and actinic lentigens. That nothing but periorbital hyperpigmentation, which is nothing but dark circles. And next is lichen planus, which is autoimmune skin inflammatory disorder. And next is Reels melanosis, post usage of any kind of cosmetic products, any kind of pigmentation or distorted pigmentation occurs over the face. That's called as Reels melanosis. Next, I said like dermatosis papulosa nigra, which occurs over the face with dark spots, elevated spots. Next is phytophotodermatitis. This is nothing but a post ingestion of some components and then exposure to the sunlight. So the pigmentation can appear over the face or body. And next is flagellate dermatosis, which can be little irregular in shape. And next is erythema dyschromicum perstans. This occurs with the erythema and inflammation, so which persists for a longer period of time despite of the treatment. And next is cervical poikiloderma. This is nothing but the pigmented spots or pigmentation, patch discoloration over the neck. And next is acanthosis nigricans, which normally we can expect over the face, neck, underarms, and thighs, or anywhere other part of the body. And next is cutaneous amyloidosis. This is a protein deposit disorder where it can be expected more over the forearms, arms, back, and sometimes over the thighs. And next is reticulated confluent dermatitis, which is again a confluent nature with the dark spots occurring in the lacy pattern. And next is idiopathic guttate with guttate pigmented lesions over the body. Next is epidemiology. So it is a hyperpigmentation of the face of the body is the second most frequent complaint in the population, which comes with the specific age group about 15 to 30 years. It is most common complaint in the population aged 40 to 54 years. Prevalence of melasma in India is high in unexposed areas at higher altitudes. It is found in all races and ethnicities, and most the female to male ratio is about 3 to 2. So 90% of the women and 10% of the males, and in Fitzpatrick skin type 3 and 4, melasma can occur most commonly in these kind of population. Next is in prevalence of melasma in general population is about 1%, and high risk of population about 9% to 50%, with the average age of onset ranging about 20 to 30 years. Study, like I said, female to male ratio is about 4 is to 1. Prevalence of hyperpigmentation. PIH is prevalent in both males and females, as it can occur due to any kind of injury or acne-induced hyperpigmentation in most of 70% of the cases before age of 30 years. And actinic lentigens is more common in fair to medium tones photo age skin. And it is also very common in India, and one third of women in age group more than 50 years are affected, and it affects more than half of the population aged about 70 years. What are the causes of hyperpigmentation? The first most important thing is ethnicity and the race, because of the type of skin, because of the genetics and the type of receptors, the type of genes present with the melanocyte. So that plays a huge role. And next comes UV exposure. Post UV exposure, UVA radiation or BB radiation, most likely UVB. So this causes increased melanocyte activity and increases more melanin, and that's when the pigmentation starts. And next is altered melanocyte function can be due to any of the trauma or injury related. And next is genetic factors. It can occur due to genetic factors as well. And then drug induced hyperpigmentation, most commonly are oral contraceptive pills and other antihypertensives, isoniazid, and some photosensitizing drugs which have been taken. Post that, they develop pigmentation over the face or body. And next is hormonal, which is most important in the females, where estrogen predominance causes more of pigmentation over the face, and especially in the pregnancy, which is again I mentioned, which is called cloasma. And the last but not the least is immunologic. Post this toxin-induced destruction of the melanocytes, any kind of products used on the face or any kind of treatment taken on the face. So that can also cause melanocytes. For example, constant use of steroids. So methods for diagnosing hyperpigmentation. So we can go with the history. We can ask for the history of any prior inflammation, like in the cases of acne, eczema, psoriasis, viral exanthems, and arthropod or trauma. History of hyperpigmentation should always include onset of disease, like when did it start and how did it start, and how did it even spread, and what medications were used before for that to be corrected, and and course of the disease, for example. And then again, disease progression, and any kind of creams or medicine which was used, and the patient is little dependent on that kind of creams. So that history becomes very important in terms of Indian population because of the steroid abuse. And then again, occupation history, people working in the fields and then mining and other were exposed to the lot of UV radiation in visible light or beat for any kind of, even though right now, even the latest study, even the blue light from the phones or the tablets, even these can cause any kind of pigmentation. And also come of family history. Physical examination includes by observing a small to large hyperpigmented patches of various sizes. Normally, they come with hyperpigmented, well-defined patches in case of epidermal melasma, and ill-defined patches in case of dermal melasma. And then this, which excludes mainly by a dermoscopy, which helps in knowing all kind of knowing the different levels of the skin affected by the melanin and melanocytes. And then even we should not do not have to ignore about the examination of nails and mucosa. Systemic screening, IHC, CBC, liver function test, monitoring of blood glucose, because of in diabetics, hypertensive, when they're more prone for pigmentation. Most importantly, it's a hypothyroidism or thyroid disorder, because thyroid disorder again indirectly stimulates melanocyte stimulating hormone, and that again causes increased melanin distribution over the skin. And again, serum B12 levels is nothing but knuckle pigmentation and the feet pigmentation. So these are the signs we can see where if the B12 levels are low, these are the pigmentation to be looked for. And yeah, and then next, coming to the physical test like a UV light examination, dermoscopy, as I mentioned, wood slam. In case of epidermal melasma, it can be accentuated. If in the case of dermal melasma, it just remains the same on wood slamp examination. And reflectance confocal microscopy, potassium hydroxide scraping test, KOH test, to rule out any kind of tinea or any kind of fungal infections. And biopsy, to know how the melanocytes and what kind of inflammation at what level it's involved. And MACSI is melasma area severity index. So we calculate according to the area of face involved with the formula. And mixometry is again knowing the thickness of the face with the pigmentation where all it's involved. How do we manage hyperpigmentation? So first we have to go with traditional methods, going with the pigmenting and targeting for the targeting for the melanocytes and melanin distribution. So it always works on the different various we have to focus more on various cell receptor antagonists, inhibitors of the melanocyte stimulation, and tyrosinase enzyme inhibitors of the melanocyte transfer, and degraders of melanin in keratinocytes. Hyperpigmentation can be used in following can be managed by using, first most important thing is photoprotection. Broad range of sunscreen spectrum, you covering UVA and UVB with physical and chemical filters. So in kind of hyperpigmentation, I always look for iron oxide, which is the most important filter, a physical filter to reflect all the UV radiations. This should be applied over the face and neck and ears, and to be repeated 3 hours later, and make sure it's applied 15 minutes prior stepping out, and it should be applied every single day, 365 days, irrespective of the seasons. Next coming is physical protection like hats and wide brim caps going on a vacation time, or full arm clothing. Next, clean lighting agents we go for, which is we have topical and natural, which I'll deal with later, and oral agents like tranexamic acid and oral vitamin D, and physical therapies like chemical peels, microneedling, and laser, like most importantly Q-switch laser. So let's first come with the photo protection, which, like I mentioned, broad spectrum sunscreen covering the clothes and accessories. Sunscreen, I'll always look for more than 30 SPF, which is more recommended in terms of melasma and PIH. And visible light blocking sunscreen such as iron oxide containing formulation should be included in any kind of sunscreens to protect from any kind of harmful radiations. Also, any kind of treatment being taken, everything fails if at all the sunscreen is not applied every day. Next is skin lightening agents like topically. We've used conventionally topical hydroquinone, which has been gold standard for treating facial hyperpigmentation. It's a bleaching agent which also goes in inhibiting tyrosinase, which tyrosinase is an enzyme which converts dopa to dopaquin, a dopaquinone, and then dopaquinone will cause eumelanin and pheomelanin. These are the two types of melanin which is present in lighter and darker skin shade. And this hydroquinone goes and inhibits this main culprit, which is the tyrosinase enzyme. And topical hydroquinone can be used alone or in combination with retinoic acid or glycolic acid, and it also comes with the Kliegman's regimen used with in the topical. Hydroquinone 4% with 0.05% of tretinoin and 0.1% of mometasone or fluocinolone, or more, depending on the potency of the steroid, topical steroid. And then coming to the retinoids, these are structurally and functional, similar to vitamin A, which lighten the skin by modulating skin proliferation and also through anti-inflammatory activity. It is the most commonly used are tretinoin, tazarotene, and adapalene. In a double-blinded RCT of 54 black women, 0.1% tretinoin was found to be superior in lightening the skin of patients with PAH when compared to the vehicle. Next is azelaic acid. Azelaic acid is nothing but it helps in inhibiting the tyrosinase enzyme again and exerting selective cytotoxic and anti-proliferative effects on melanocytes, ultimately decreasing melanogenesis. It is used for treating melasma and PIH. It comes in different combinations: 10%, 15%, 20%, which we normally used on daily basis. And 20% of azelaic acid was effective as equal to 4% of hydroquinone. For a longer period of time, we can use azelaic acid, but hydroquinone we cannot continue for more than few weeks, as purely for the rebound phenomenon or exogenous ochronosis cases. So other lightening agents include glycolic acid, mequinol, and chitin, and more. I'll discuss further. Natural agents like kojic acid and again inhibits catechylase activity of tyrosinase. It is also very helpful in case of melasma, and it is not. It can be used as it can be combined with other agents, but not as a monotherapy. It is lesser effective, but combined with others, it is more effective. And again, next is glycolic acid, which is naturally occurring alpha hydroxyamide obtained from a sugarcane. It comes in 20% to 70%. Neutralization can be achieved with water. It is generally considered to be the gold standard chemical peel for treating melasma. Salicylic acid is more for the acne prone patients, but glycolic is more for the melanin or pigmented patients. Next is tranexamic acid, which inhibits UV-induced plasmin activity, ultimately impairing melanogenesis. It is a promising systemic treatment for melasma or as monotherapy, and also it can be combined with other Kliegman's regimen as well, or in later stages with the laser therapy as well. And vitamin D, 1,000 international units, as works as an anti-inflammatory, also works with in the patients of high risk patients with severe pigmentation due to sun exposure in pre-existing PIH patients. Physical therapy is microneedling. This is the procedure which involves use of an instrument studded with the microneedles that is rolled over the skin to reach upper dermis, 0.5 mm, to induce a wound healing response. Rucinol or Sophora alpha serum were evaluated with and without microneedling. This procedure mainly helps in better penetration of the topical agents and better efficacy of these agents work when they enter in the deeper level of the skin. So microneedling combination group showed a significant decrease in melasma area severity index score compared to the serum alone. In a randomized study, treatment with microinjections of tranexamic acid combined with the microneedling showed a greater improvement of hyperpigmentation melasma patient than in control treatment. Next is chemical peels. Like I suggested, the superficial peels and deep peels. This helps in exfoliation, reducing tyrosinase activity. The most important peel, what we also look for, is salicylic acid and trichloroacetic acid peels, TCA peels. And photo protection and use of hydroquinone for the priming is becomes more important before starting any kind of chemical peels. And next is laser therapy. It's a usually second and third line the treatment approach. The major drawback from when this is used in melasma, what type of lasers we use? Normally it's Q switch laser, picoseconds laser, which can be ablative or non-ablative lasers. So when they are used in melasma patients, especially in the type of skin color, and the high risk of PIH can occur. So that's why it can be taken as a second and third line of treatment. And yeah. What are the recent advances? SLC or NLC liposomes or nanosomes, phytochemicals, fractional photothermolysis, and PRP, which we'll discuss further. So the key practice points is that Mulla et al. Have recommended a list of key practice points. First is photo protection and sunscreen use are the cornerstones of therapy. More than 30 SPF, and first line therapies are hydroquinone 4% or combination with hydroquinone, which is a triple combination therapy. The future triple combination can become the something called flutamide, which is estrogen receptor antagonist, which is more commonly being dealt with the women due to the hormonal pigmentation. So flutamide and VEGF inhibitors and hydroquinone. These three can become a future triple combination therapy. And then retinoids, of course, 0.1% of tretinoin or 0.1% of adapalene or tazarotene 0.1% can be used as a first line therapy. The only adverse effects can be like burning, skin dryness, and retinoid dermatitis and PIH. And then the other topical treatment includes azelaic acid and topical tranexamic acid, glutathione, kojic acid, alpha-arbutin, cysteamine. And for patients preferring oral medications, we also give oral TXA, which is oral tranexamic acid, ranging from 250 mg to 500 mg. It can be given to patients who have previously evaluated with a good normal renal function test and CBC. And it's completely safer to use in patients, apart from patients with the dysregulated clotting mechanism. So it also helps in inhibiting tyrosinase activity, and also helps in used with the triple combination, and oral tranexamic acid works better. And only the adverse effect can be abdominal bloating, headache, and hypomenorrhea in women. And chemical peels and lasers are only recommended for refractory or persistent lesions. So the first thing is, let's look for the treatment of pigmentation. Hyperpigmentation includes use of phenolic and non-phenolic agents, and sunscreens and moisturizers become very very important to maintain the good skin barrier, also for the good sun protection. And conventional hydroquinone has been a gold standard, 2 to 4% of treatment as a first, with combining with the retinols and topical steroids. And then again, kojic acid, alpha-arbutin 4, and butyl resorcinol are promising ones. So if the patients are allergic to retinols, they can still go for something called bakuchiol, which is a plant extract basis, which helps in dealing with the pigmentation. Again, combination therapy always works better than monotherapy in terms of hyperpigmented patients, or like more specifically melasma patients. So gentle procedures are preferred than for going for the deeper procedure, like deep peels cannot be taken chance in kind of pigmentations. And lasers can be used if any of the topical or oral treatments fail, then lasers come in place. The other treatment, what apart from melasma, we do have other pigmentation situations, like lightened planus pigmentosis, which is a patchy discoloration over the band of pigmentation over the forehead and face, or the neck, chest, back. And these are really stubborn to the treatment of oral treatment or topical agents. So we normally give oral cyclosporin, or oral that is immunomodulators, or oral isotretinoins with the tapering ones. And also topically we use tacrolimus. And next is facial acanthosis nigricans, with because of the insulin treatment or PCOD patients. So this becomes very important in terms of the neck pigmentation. So normally we go ask for them for the dietary and lifestyle modifications. Along with that, we also put on topical retinoic acid. at night, and morning for a strict sunscreen protection. And next is uh, next is PIH, which is a post-inflammatory hyperpigmentation. In these cases, we also use kojic acid, azelaic acid, and oral PIH is best managed with the tranexamic acid, and it can be the triple combinations. Normally, we do not use it because of the very thin skin tissue over around the mouth. So we normally keep it very safer and little lesser concentrated peels over around the pH areas. Next is POH, is perioral hypermelanosis. Here we use glycolic acid chemical peels 20% or lactic acid. Along with that, for a maintenance, we use hyaluronic acid with under eye creams for in case of under eye periorbital hypermelanosis. In their case, we use under eye creams which contains hyaluronic acid, kojic acid. For over a period of 6 months. So the future directions are now the newer agents target hyperactive melanocytes. So first coming with linoleic acid topically, which inhibits tyrosinase. NCAP topical, again it causes tyrosinase inhibition. Again, next targeting melanogenesis is alpha arbutin, which is topical, then aloesin, which is derived from the aloe vera, rucinol, flavonoids, and epigallocatechin, gentisic acid, hydroxycoumarins, and cinnamic acid, and antisense oligonucleotides. So all these help in tyrosinase enzyme inhibition. Next is the agents which normally we target on is reactive oxygen species, which normally can come from the sunlight, UV radiation, or any kind of pollutant, or any kind of harsh chemicals. So this causes inflammation and damage to the skin. So we need something called antioxidants. So licorice extract, pyocyanidin, acidified amino acid peels, orchid extract, coffee berry extract, mulberry extract, pycnogel. So these are all the ones which have stronger antioxidant effect on these melasma patients. And next are the agents which target melanosome transfer, that is transferring the melanin from the keratinocytes to the melanocytes and to the epidermis. So we need to target them to block. So the first most important we all are aware of is topical niacinamide and soy milk, and topical liquidin. And there are the other agents which also target defective barrier, that is soy milk topical ones, which restores the skin barrier because of the inflammation. The skin would have undergone for some stress, so this helps in repairing the skin barrier. And the most importantly we've talked about is the tranexamic acid. This oral tranexamic acid also targets the vascular component, because any kind of patient coming with the melasma who have a lot of inflammation and redness, so they benefit a lot with the tranexamic acid oral, and which by this works by inhibiting plasmin or plasminogen activity, but indirectly inhibiting melanocyte and keratinocyte interaction. And so dermatitis are associated with melasma such as erythema. This can be dealt with tranexamic acid. So next is topical flutamide. I was talking about this is anti-androgenic, which in the case of hormonal imbalance because of the estrogens and progesterones, in terms of during pregnancy, post pregnancy, and also during the menopausal time. So because of this estrogen dominance, we deal with a lot of pigmentation issues in women. So that's why this topical flutamide helps in indirectly and being inhibiting androgen receptor, also indirectly reducing alpha melanocyte stimulating hormone. Also next is yeah, so the first one, the most important, the class. This is the classification of agents, which shows based on the level of evidence. The main one as a antioxidant, also working as reducing melanin, epigallocatechin, pyocyanidin, mulberry extract, coffee berry, and lecithin. And the second one as linoleic acid, arbutin, aloesin, rucinol, pycnogel, soy milk, zinc, flutamide, and NCAP is N-acetyl 4S cysteine amine, aminal phenol. So, no, we all know about what is hormonal imbalance. We keep talking about in case of pigmentation, melasma patients in women. So, this is the main etiology. What pathogenesis is: increased estrogen and increased progesterone will also and also increase alpha melanocyte stimulating activity, increase estrogen receptor alpha and estrogen receptor beta. So again, what happens here? What these go and again include increases a KIT receptor gene and also TYRP gene, tyrosine receptor proteinase, which is present over the skin. So they go and stimulate them, and that's when the pheomelanin and eumelanin pigmentation start dominating in this kind of pigmentation. So that's why it becomes very important in hormonal patients, like for suppose having post pregnancy chloasma, melasma in case of um, uh, uh, in case of patients who have gone for menopause, postmenopausal, even the target becomes estrogen receptor. So that's when flutamide becomes important. Also, they can be treated with tranexamic acid and dimethyl hydroxyfuranone. So the latest most alternative vehicles for drug administration are SLN prepared hydroquinone has improved efficacy than a standard topical hydroquinone. So they have other drug vehicles like liposomes and microemulsions, and pharmacological therapies like topical metformin, flutamide, isobutylamide, thiazole, resorcinol, platelet-rich plasma for the treatment of melasma and PAH, and newer non-pharmacological options include using of microneedling and picoseconds laser. So here the PRP, what I was mentioning is platelet-rich plasma. They come as the platelets have alpha granules which produce 8 to 10 types of growth factors, which includes more importantly platelet-derived growth factor, vascular endothelial growth factor, yeah, endothelial growth EGF. So there are different types of growth factors which help in reducing tyrosinase activity and reducing melanocytic activity, and also being antioxidant effect over that, and also produces gives a good effect on the skin by using the platelet rich plasma in monthly once for 6 sessions. So the take-home message is hyperpigmentation is a dermatological skin condition which is characterized by patches of skin, darker patches on the skin than the surrounding, which looks darker than the surrounding skin, and it is of three major types, which is like in Indian scenario we see PIH, melasma, and actinic lentigines, which are more like freckles, and it is the most common complaint in the population with 40 to 54 years, irrespective of the gender or skin color. Hyperpigmentation is triggered by multiple factors, the most important being genetic, hormonal, UV radiation, ethnicity, race, and multiple drugs. And hyperpigmentation is managed using photoprotection, skin lightening agents, oral agents, and physical therapies. The future directions for managing hyperpigmentation include alternative vehicles for drug administration. SLN is nothing but solid lipid nanoparticles, and pharmacological therapies using topical metformin and flutamide, and non-pharmacological therapies like picosecond lasers. So, a beautiful skin requires a commitment, but not a miracle. Thank you.
Yes, hello, doctor.
Yes, hi.
Yeah, so I'll just check if any queries. Okay, currently I see there are no queries. We'll wait for a minute or two.
Yeah, yeah,
I
sure.
request all the attendees, if any queries, please post in the chat box. Okay, so I see there are no queries from the audience. So with your permission, we can end the session now.
All right. Thank you.
Yeah, thank you for presenting and sharing your knowledge with all the attendees. Thank you.
Thank you.